Welcome everyone to this webinar, and welcome. This is a very special webinar for the EPOS about the non-surgical treatment of strabismus and nystagmus. I'm Dr. Mahad Basha, and I'm honored to co-moderate this webinar with Dr. Ahmed Aladdin. And I'd like to give him a shout out because he's the one who organized and did everything in preparation for this webinar with his fantastic team. Also, we'd like to thank Pharma for sponsoring this meeting. Today we have an outstanding panel. We've got high caliber experts from 3 different continents, and we're delighted that they accepted our invitation and fit our webinar in their busy schedule. So I'm sure we're going to learn a great deal from what they have to say. Dear audience, this is your webinar, and we want it to be an interactive webinar, so please do participate. First, by answering the poll questions as they come up, and if you have any questions, please post them in the Q&A section at the bottom of the screen. Our dear speakers will answer these questions in between their presentations. And without further ado, I'll hand the mic now to Dr. Ahmed Aladdin to introduce the speakers.
Thank you, my dear colleague, Dr. Mahad. Today, you are honored to have with us Professor Kyle Arnoldi. Kyle is a chief consultant at the Ross Eye Institute and an assistant clinical professor in the Department of Ophthalmology at Buffalo University in New York. She is the director of the Orthoptic Fellowship Program at Ross Eye Institute, and she's also the editor-in-chief of the Journal of Binocular Vision and Ocular Motility, formerly known as the American Orthoptic Journal. So she would be the one endorsing many of the rejection letters that we all get. We are also delighted to have with us Professor Dr. Richard Hertel. Dr. Richard is the Chief of Pediatric Ophthalmology and the Children's Vision Center at Akron's Children's Hospital in Ohio. He is the Director of the Pediatric Ophthalmology and Strabismus Fellowship Program, the Dr. Robert Boomer and Jill Bernstein Chair Professor of Ophthalmology. But most importantly, Dr. Hertel is the world known icon for nystagmus. Nystagmus is a hard topic even for an expert pediatric ophthalmologist. So today you are looking forward to hear his talk about nystagmus, and we are going to bug him with a lot of questions as he requested. We are also honored to have with us Professor Rosario Gomez-Didiano. Dr. Rosario is a professor of ophthalmology in the Universidad Complutense de Madrid in Spain. She is the president of the International Strabismological Association and the ex-president of both the European Strabismological Association and the Spanish Strabismological and Pediatric Ophthalmology Association. Finally, I'm honored to have with us Professor Dr. Lobna Khaznak. She's my mentor. She's a professor of Pediatric Ophthalmology and Strabismus, and also the ex-head of the Strabismus unit in my beloved university, Cairo University. So let's kick in. But before I handle Kyle, I'm going to ask the audience to share with them one of the polls before asking Kyle to put in her talk. So this is the first poll we have with us today. It's about convergence insufficiency. So what line of treatment would you recommend for a patient with a convergence insufficiency? Would you prescribe reading spectacles, bathe-in route, pencil push-up exercises, computer vision therapy, or request surgery? Let's see what the audience will vote before then we go to Kyle's talk. So here are the results. Most of the audience are in favor of the pencil push-up exercises. Do you agree with the time?
I do sometimes use that, but I find most of the time the pencil push-ups are not very effective. Sometimes it's because they're being done incorrectly. But other times it's because it depends on where the anomalies are in convergence. There are some patients who have a very good near point of convergence, but they can't sustain convergence when they're reading. So my approach to those patients is very directed towards whatever I uncovered on my exam. I chose the computer orthoptic exercises, by the way. So I'm going to share with you today. I'm not advancing here. There we go. My approach to patients who are sent to me for non-surgical management of diplopia. And I approach it in 3 steps. The first step, I have to make sure the patient actually has double vision, because the words double vision mean different things to different people. My next step, within my exam, I'm going to determine where or what is the problem, because strabismus is only one problem that can lead to double vision. And then finally, how should it be managed? Because sometimes prism isn't the best option, though it's the one we tend to think of first. So I'm not going to belabor the first step. This is something that you will reveal with careful history taking. But remember that double vision to some patients means strabismus. To others, they will deny having double vision and then proceed to describe to you visual confusion, which is, of course, the counterpart. Others may report monocular blur, monocular diplopia, but you could even get a case of visual perseveration that may manifest as diplopia, such as a cerebral polyopia. So it's worth investigating there a little bit. First, we'll talk about where is the problem. And I like to sort my patients into 3 main categories. Those who have diplopia because similar images are falling on non-corresponding points, those who have monocular diplopia due to unfocused light rays, and those who actually have an inability to fuse images that are already being projected onto corresponding points. And then I'll talk about how to manage each of these categories and the different tools that I use: prisms, orthoptic exercises, optical management, and worst case scenario would be fogging or occlusion. So the first group is probably where most of our patients are going to fall, and these are the ones who have diplopia because similar images are falling on non-corresponding points. So in this diagram here, of course, we have an esotropic eye. So the object that is straight ahead is projecting onto a deviation point, which in this case, because it's esotropic, is projecting temporally, giving us double. And whatever happens to be in space lined up with the fovea of the deviating eye is projecting its image straight ahead, so visual confusion can be a problem. I actually find that many of my adult patients are more bothered by visual confusion than they are by diplopia. It's worth asking about. So the greatest percentage of patients in this category are the ones with strabismus. They're the ones that we're most familiar with. Diplopia is present under binocular conditions. In general, the smaller the angle, the more bothersome the diplopia. And they often tell me that the double is worse when they're in dim light viewing a bright stimulus. But there's another group that falls in this category. And I'm seeing more and more of these patients in this century. And they are the ones with a maculopathy, the ones that I refer to as having retinal diplopia. This is true binocular double vision, but the symptoms don't always correlate with your exam. So for example, the patient is complaining of vertical diplopia, but your measurements show a physiologic exophoria. Or you might find a vertical tropia, but the offsetting prism does not relieve the vertical diplopia. Their double vision is worse in bright light, and the diplopia is almost always vertical or diagonal. Now, for our strabismus cases, the management can be very straightforward. I like using prism a lot. This is especially useful when the angle is small. I really try to limit the amount of prism that is ground into the glasses, because even with as little as 7 prism diopters on each side, I find my patients suffer with a lot of aberrations that sometimes are not tolerable to them. But I'm only going to use prism in patients that I know are capable of sensory fusion, and I've discovered this through my sensory motor exam. It's also best when you have a fairly concomitant deviation, but that's not absolutely necessary. If you can find a prism that gives the patient single vision in primary and into down gaze, it's worth a try. Now, some of the patients are actually going to do better with orthoptic exercises. These are patients who actually may have larger angles of strabismus, but the difference is they have at least some control. It might be poor, but they have some control upon which I can build. If I have a tropic patient, I am not going to try to teach them fusional vergence. These patients who do well with orthoptic exercises are also those who have no limitations on their versions. So their strabismus is not due to a palsy or restriction. Refractive correction can be helpful for those with horizontal strabismus and accommodative components. Obviously, we've got our accommodative esotropes. Adults will come to me right around the age where they're becoming presbyopic and complain of esotropia with diplopia, and then I find out that they were accommodative esotropes as children. But the other group that does well with refractive correction are the intermittent exotropes who have a high ACA ratio. Sometimes I will over-minus them to assist them with control of the deviation if they don't want surgery. Now, fogging or occlusion, this is going to be my last resort for this group, but there are some patients with strabismus who are incapable of fusion, and then I have to go with some type of occlusion. Now, the cases of retinal diplopia deserve just a few extra seconds of discussion because it's such an unusual type of double vision. So in the patient whose eyes are straight and the retinal elements are aligned, light rays come in, they stimulate corresponding retinal areas, sent to the visual cortex, and fusion results. But in the patient who has traction on the macula, such as we find with an epiretinal membrane, now we have displacement of those outer segments of the photoreceptor cells. So even though the eyes are aligned, when the light enters the eye, they are falling on retinal elements that have completely different localizing values. So the information sent to the cortex is not fused. So in these cases, we may have straight eyes or may have a small strabismus. The important point is that the retinal elements themselves are not aligned. This is a very difficult group to treat. And the first thing I do is warn the patient that I can make it better, but nothing I do is really going to make it go away full time. I do use prism sparingly. I use the least amount possible for fusion, even though patients tend to want more and more. I avoid prism when I have vertical diplopia with no vertical deviation. And I try to encourage part-time wear, because I find that these patients, some of them, will adapt to the prism and they want more and more and more. Orthoptic exercises really aren't helpful here and in fact may be contraindicated. And this has to do with the adaptation that is happening naturally. So these patients tend to have increased vertical fusional amplitudes already. If I increase them further with exercise, I fear that this may lead them to eat up more prism. So I try to avoid that here. But I do use refractive correction. This is best in the patient who has no metamorphopsia and good spatial localization. So what do I mean by that? Some of these patients, when they are fixating with the involved eye, will tell me that the image appears to move. And I think this may be because the cortex is having a difficult time localizing it in space relative to the eye without the membrane or without the traction. So when a patient reports that to me, I don't always use these methods. What do I do? Well, sometimes it's as simple as maximizing the acuity in the dominant eye if the dominant eye is the one that's unaffected. But I've also used monovision, and it may be spectacle monovision in some of these cases, where I correct the dominant eye for distance and the non-dominant eye for near. This doesn't entirely correct issues with fusion and stereopsis, but it can minimize the double vision. Now, fogging or occlusion really probably is the standard of care for this type of double vision in the United States, but I haven't had much success with it. Most of my patients really don't tolerate the blur very well. I will give it a try when the non-dominant eye is affected, and if there is metamorphopsia present, I will lean in this direction, or that poor localization that I've talked about. The type of fogging I use will be with a Banggood filter or adhesive tape. And I try to, rather than cover the entire lens, just cut out a narrow strip right through the optical center and into up and down gaze. Now, our second group are those who have the monocular diplopia, where we have unfocused light rays projecting a second image onto the same retina. This is a double vision that does not disappear with covering one eye, but may disappear or at least improve with a pinhole. Once again, we have a group in this category that's very familiar to us, those with uncorrected refractive error. And it may be a simple myopic astigmatism. But remember that some of these patients will improve with pinhole, but not with spectacles. They may have irregular astigmatism or higher order aberrations and require something a bit more. Once again, there's another group of patients in this category. And just like the retinal diplopia, I'm seeing more and more of these patients with the passage of time in my practice. And those are the patients with dry eye. They have a monocular diplopia, which can be partially relieved with pinhole. But the problem here is that the tear film deterioration leads to an irregular corneal surface, and that can lead to higher order aberrations. So usually these patients, I don't manage them at all. I send them off to our anterior segment people to manage their dry eye. But what about our patients with the refractive problems? Well, prism is really not helpful in this group. Neither are orthoptic exercises. This is going to usually come down to refractive correction. Spectacle correction of refractive error, that's easy. Switching from spectacles to contact lenses can actually help in many of these patients, but some of them are going to require something a bit more invasive, and I will be sending them on to one of our other services. Worst case scenario, we have to go with fogging, only if nothing else works. Our final group are those who have double vision because they have an inability to fuse images that are already falling on corresponding points. Fortunately, this is the smallest group of patients because it is also the one that is most difficult to treat. They also have a very different type of double vision that they will report to you. Often that second image will appear to float around, or they'll tell you they can't really tell where it is. So you ask them, where is the second image? And they don't say it's to the right or it's above. They'll say to you, I don't know, I can't tell, which seems like a very illogical response, but it really does happen in certain cases. One subset of these patients are those who have extensive visual field defects. If you have a homonymous hemianopia, you're not going to have diplopia. These are the patients who have heteronymous and incongruous visual field defects. What that does is it reduces the number of matching points in the cortex between the two eyes. And the cortex has a very difficult time keeping the eyes lined up in that situation. So you'll get the sensory strabismus, and with diplopia that doesn't really respond well to a lot of treatments. But also in this subgroup, you might put in the patients with maculopathy who don't really complain of double vision, but have anisoconia or metamorphopsia. So they have images that are very different falling on their foveas, and that makes them unfusable. The second group of patients in this category would be those that have some sort of cortical problem. So this includes our paradoxical diplopia that's due to anomalous binocular correspondence, but it also includes patients with a central loss of fusion or horror fusionist. This may be due to a brain injury, but it also may be due, in my experience more commonly, to aggressive anti-suppression therapy. So our patients with the visual field issues, I do use prism here, but not the yoked prism that you sometimes see prescribed for the patients with the homonymous hemianopia. In this case, I might be using prism to shift the image into a scotoma. I might actually be making a strabismus worse or creating one in order to relieve the patient's symptoms. Orthoptic exercises really don't play a role here. In refractive correction, we can use isoconic lenses. Now, these work really well when you have anisoconia due to anisometropia. They don't work as well when the anisoconia is due to a maculopathy, but it might be worth a try. And then, of course, as I've mentioned before, the monovision might work here as well. Unfortunately, a lot of these patients end up with fogging or occlusion because many of them are incapable of fusion. And once again, I will use the Banggood filter or adhesive tape applied in that vertical strip right through the optical center of the glasses. Now, our final group of patients, prism, not really helpful, and in fact, in some of them, contraindicated. Those patients who have the temporary paradoxical diplopia following realignment with surgery or glasses, if you put prism on them to eliminate their double vision, all you're doing is reinforcing the anomalous correspondence, and it won't go away. So you don't want to do that. And prism for those with a central loss of fusion actually tends to make their symptoms more bothersome because you're putting the images closer together, but they're not really fusing together. I do use orthoptic exercises, but perhaps not in the way you might think. I'm not using vergence exercises here. If I have a patient with a central loss of fusion, especially those with secondary to aggressive anti-suppression therapy, or those who have the paradoxical diplopia, I try to encourage them to suppress. And I've had several patients successfully managed by relearning suppression. Refractive correction, not too much of a role in these cases, but unfortunately, many of them end up with fogging or occlusion because so many in this category are incapable of fusion. So to summarize, remember that strabismus is not the only cause of diplopia. And when it comes to our non-surgical options, we have to choose the right tool for the right job because we don't want to make things worse. So when you have diplopia, you might think of prisms first, and that's great if the angle is small, if the patient has good fusion potential, if the deviation is relatively competent, and the patient already wears glasses. But you do have other options, orthoptic exercises, for those who might even have larger angles, but they've got some control upon which to build. They've got full ocular rotations, and they're in good general health with good fusion potential. The refractive, the optical route to correcting the diplopia may be useful for those with monocular diplopia, retinal diplopia, and those who basically have straight eyes but have double vision, whether it's monocular or binocular. And of course, the fogging or occlusion. Here you see a picture of a Banggood button. So it's a small area cut out of a Banggood filter, put right on the optical center of the lens to address the diplopia from a retinal diplopia issue. But this is also good for those with poor fusion potential and a poor candidate for other methods. Thank you.
Please unmute yourself, Dr.
I just have a few questions for you. When using prisms for correction of diplopia, you fully correct the angle, or you have to leave a small foria for the patient?
I always leave a small foria if the patient can manage that. I give the least amount of prism possible. Leaving a small foria is going to stimulate the vergence system to improve fusional vergence amplitudes. When I give someone a prism, my goal is ultimately to get them out of the prism. That doesn't always happen. But to get them out, I'm going to have to increase their fusional amplitudes, and leaving them with a small foria is the best way to do that.
Okay. And which test do you use for checking for paradoxical diplopia before surgery?
Okay. My favorite test for this is actually the after image test. I did a study years ago with one of my former students, and we compared a bunch of different tests to see which one was the best. Now, there were patients who demonstrated paradoxical diplopia on other tests that were less dissociating. The reason why I like the after image is because it's very dissociating. And the patients who demonstrated paradoxical diplopia with that were the ones who were most likely to experience it after surgery. But the key, if you don't have an after image, the key is to use a fovea to fovea test. So if you have a Worth 4 dot or Baglini glasses, that's fine, but you need to do it with the deviation offset with prism.
Even if we predicted the paradoxical diplopia, can we tell whether it will be transient or will be permanent?
When I find this on my preoperative exam, I discuss this with the patient. Honestly, there are some personality types who don't do well. Those who are a little obsessive compulsive or a little nervous, they can't stop looking for that second image once their eyes are aligned. So if I get the sense that my patient is one of those, I'm going to have a serious talk with the surgeon. Most of the time, though, I give the patient a little pep talk before the surgery. And I tell them, oh, this test has shown me that there's a slight risk that you might notice a faint image off to the side. Just ignore it, it will go away. I explain to them why, but I do tell them, don't go looking for it. And one day you'll wake up and realize that it's gone. So my interaction with the patient and sensing their willingness to do this, their ability to be more relaxed about it, is key in managing this. I do have 2 patients that come to mind immediately who have had paradoxical diplopia for decades. And they have that personality type, they cannot let it go. But the good news is, both of these cases developed this paradoxical diplopia with surgery in childhood. They have both grown to be productive adults, they have college degrees, the double is there, but they're able to cope with it. So to me, the presence of ARC and paradoxical diplopia is never a reason to avoid surgery. Just have to approach it the right way with the patient.
Okay. Regarding the third type of diplopia, when the image goes in corresponding retinal points but still is not fusing,
Yes.
what kind of treatment would you offer for this patient?
I have tried prisms in the patients who have central loss of fusion due to some head injury. One of my patients still to this day wears her prisms and every day gets up with this mindset that she's going to try to fuse. She hasn't made any progress in terms of my test results, but she wishes to continue. So I don't have much luck with prisms in that group. Fortunately, it's a small group, but that's the problem. I do have a handful of patients that ended up with me because they developed diplopia after aggressive anti-suppression therapy. What I do for them is I try to reteach suppression. Initially, I have to break their concentration on the diplopic image, and I will do that with a Bangerter filter. I use one that's very dense, and I will use that over the non-dominant eye. And then fairly rapidly, but gradually, reduce the density of the Bangerter filter until finally we can remove it. I found that the patients who learned suppression as children can relearn it under the right circumstances. So I've had a couple of families that have refused this treatment because they've spent a lot of money with anti-suppression exercises, and usually it's not the child who's objecting, but the parent who's invested a lot in this therapy to get rid of suppression. So I've had some people refuse the treatment, and I really don't know what has happened to them. You know, maybe perhaps they have learned to suppress again on their own. Nice.
When I worked with Dr. David Guyton, he used to put a piece of scotch satin tape instead of a Mangelter filter. How different
Yes.
from the Mangelter filter? Would it work the same?
I'm sorry, how about the Mangelter
How
filter?
different it is from the Mangelter filter?
Okay, so the Scotch satin tape is very effective, but it's very dense. So this is something that if I have a patient who's got the retinal diplopia and I'm talking to them about fogging, rather than have them purchase the filter, sometimes I will say, let's try the tape. You tell me how well you can tolerate this, and if you like it, then we'll go with the filter. In my experience, those patients who have retinal diplopia that require the fogging, they need a pretty dense filter. Most of them cannot get by with one of those milder ones. But I always try. I have a filter bar, and I will always try them in the office with the lights on and the lights off to see what is the weakest filter that they can get some relief with. But yeah, it's very similar. It's just very dense.
Okay. One last question. Every now and then, I get some ophthalmology resident usually coming to me in the start of residency, complaining that he cannot see binocular whenever he uses an operating microscope. And usually, filter examination is almost normal. So what is the cause behind this, and how can we manage such cases?
You know, that's a good question. I've had that too. I've actually, I think one of the cases, one of our residents, he actually did have reduced binocular vision. He was a monofixator and didn't know it. I think every case is different. In some cases, it could have to do with the optics of the microscope. You know, it's a very different type of visual environment looking through a microscope. You don't have, you know, you've got these eyepieces and you don't have all this peripheral information. And this really, it's the peripheral input that is responsible for most of our fusion. So that is being cut off by the scope. And I think some people have problems with that. So you won't find that on a regular exam because there's all this peripheral information helping them. So I think it's a tough problem to deal with, but in my experience, as the residents proceed through their residency, they're learning how to cope somehow because it's not a problem later.
Dr. Ma, questions from the audience?
Yes, for the sake of time, we have one question. Advice for a patient who has straight in primary position and double in the side gaze.
And side gazes. Okay, so this is going to depend on how far into side gaze, and is the diplopia horizontal, vertical, and how does it compare? So I have had some patients that really bothered by double vision, even though it was in extremes of gaze. I don't like giving prism for these patients, but I will do it. If they have, for example, perhaps an esotropia in side gazes, like I see some adults who have the sagging eye syndrome, and they're really okay in primary position, but they've got uncrossed diplopia to both sides. If I know, because I've checked their amplitudes, that they can handle some base out prism in primary without creating diplopia there, I might give them a small amount of prism in each lens to try to expand that field.
Great, so I think, yes, we've got a couple of poll questions. So would you like to comment, Dr. Richard?
Sure. While I'm thanking everyone. Certainly an honor to be here. Thanks, Dr. Ahmed, Dr. Maha, for inviting me. It's an honor to be part of this ePost presentation. I hope that the next few minutes are valuable for your participants, yourself, and your sponsors. My goal in the next few minutes, I'm not going to spend a lot of time lecturing because it's been my experience that in these types of forums, whether they're live or virtual, people are interested in asking questions rather than hearing me speak about things. And I don't want to talk a whole lot because almost everything that I'm going to say today is in written form. Either you can find on PubMed, just search it, or you can download Lou and mine's textbook for free at omlab.org. The publisher stopped working, and for a lot of reasons, the book is now available worldwide. If you wanted to download this with all the color photos, all the appendices, all of the videos, anything that, this is our cumulative knowledge of nystagmus over the last 3 to 5 decades. So whatever I'm going to say here is in the book. So I don't want to be too repetitive, and you can have a resource to look at it in more detail. So the first thing I want to do is talk about naming. And as I hear all the time, all of us speak and we give names to things that we're familiar with that other people may not be familiar with. So the classification system that I'll be using today is one that was agreed upon in the 2000s and is published in numerous places. It's a classification of the CMAS classification system, which was agreed upon by a multidisciplinary group of people from neurology and psychology and pediatrics and physiology, as well as in optometry, vision science, and ophthalmology. So this took a year to get together, and it seems to be a nice starting point, especially for clinical trials where we have to define terms. And the types of nystagmus that are most commonly seen, especially in infants and children, are the two that are outlined in the red: infantile nystagmus syndrome and fusion maldevelopment nystagmus syndrome, which used to be called latent nystagmus. The diagnosis of nystagmus is not clinical. The diagnosis of nystagmus is made clinically over the entire world. But my experience with this is that it's an educated guess, like many other diagnoses, a relatively educated guess. But the way to make a diagnosis of nystagmus is to combine the clinical information with eye movement recordings in much the same way as making a diagnosis of any type of physiological dysrhythmia, from EEGs to ERGs to EKGs and EMGs. These all allow us to really understand what's happening in the organ itself or deduce what's happening in the brain. And just as a brief introduction to differentiating between infantile nystagmus and fusion maldevelopment nystagmus, especially because if you look at a patient with infantile nystagmus, about 40% of them, when you cover each eye, the eye that is viewing will change its direction and jerk in the direction of its viewing. So it looks like latent nystagmus, and about 40% of INS patients will have a latent component. So the only real way to differentiate FMNS from INS is with eye movement recordings. And the slow phase is the pathology. That's the pathologic phase. That's what the brain is sending the signal to the eye muscles to either move away quickly or move too slowly. And the metaphor I like to use is getting on the freeway or getting off the freeway. When you get on the freeway, you accelerate, and the area where you're the slowest when you get on the freeway is right before you get on the freeway. When you get off the freeway, the area on the exit ramp where you're the slowest is right when you get off at the end of the exit ramp. So whether you're on the beginning of the entrance ramp or the end of the exit ramp, that's where your eye is the slowest. So FMNS is a decreasing velocity exponential. So the eye is the slowest here at the end of the slow phase. In INS, the eye is the slowest at the beginning of the slow phase, which is the direct opposite. And this is where the action takes place in the brain. The brain suppresses the world here during the fast phase and from here to here. So most of the beat, the brain is suppressing the world, so we don't see oscillopsia. The other really important thing to, when you look at patients with INS, 17 to 33% of them will have a harmonic oscillation on top of the baseline INS. And the metaphor that I use for this, especially with families, is imagine that the baseline infantile nystagmus, the baseline waveform, the baseline nystagmus intensity, amplitude times frequency, is the equivalent of an orchestra playing. And you hear music from multiple instruments and it has a relative intensity. Now imagine a soloist comes out. The soloist changes the character and nature of the music that you hear. And that soloist, it could come out every 30 seconds for 10 seconds, or it could come out for 90 seconds, then go away for 90 seconds, come out for 90 seconds. So it could happen regularly, the soloist could come out, or it could happen continuously, regular, continuous, and irregular. So on the bottom, you see a continuous, regular changing of the intensity and direction of the waveform from jerk left, stops almost, to jerk right, to jerk, to stopping, to jerk left, stopping, jerk right. And here you actually see the direction change. In most patients, it's aperiodic. So there is not a regular change. It's very simple to diagnose this, even clinically. You just patch the preferred eye, the non-preferred eye, or if they're binocular, patch either eye, and ask the patient to look ahead for 5 minutes straight ahead at a boring letter, and you videotape, or a technician videotapes the eye. And then you could go back and look at it later, maybe under faster speed. And if the eye changes in direction or intensity of its oscillation over that 5 minutes, then it has periodicity or aperiodicity. If it's staying the exact same intensity, then they don't have periodicity. So you don't absolutely need eye movement recordings. You just need to spend 5 minutes looking at the patient, which in most ophthalmologists' office are 10 to 15 patients, I think, for 5 minutes, let alone one patient. The other thing is a clinical pearl of using head postures to determine what's happening with the eyes. And I think this is a really common error, to actually say that the head position is solely due to a problem with the visual system. And this may or may not be the case in how the head posture was initiated. But in patients with nystagmus, especially nystagmus over time, or nystagmus that's been treated, we can no longer say there's a one-to-one correlation between the anomalous posture of the head and the eye causing it. So the nystagmus can change the position of the head depending upon whether there's a static gaze null, saying 20 degrees right, 20 degrees left, up or down, or torsional, whether convergence damps the nystagmus. Now you ask them to converge, the nystagmus goes away and they don't need a head posture. Whether you cover an eye, and now they have a latent component, so they're going to fix an adduction, allowing them to change their head posture, or whether they cover it themselves by suppressing the non-preferred eye and the strabismic deviation, or whether you're asking them to pursue or follow an OKN drum, which changes the direction and intensity of the nystagmus, or whether they have an underlying periodicity or aperiodicity. So looking at the head posture alone, from an eccentric gaze null alone, is really going to cause an error. And there are non-nystagmus components. Two we've looked at recently in more detail over the last couple of years, and this is the muscular component and a component that's called egocentric localization, which is an anomalous wiring of the brain stem's relation to gravity, which is what is pitch, what is yaw, and what is roll, depending on how the brain stem is related to gravity and how the patient grows up with it. And you can check this anomalous egocentric localization very easily yourself, again in the office with a patient with nystagmus. You physically straighten the head, put them in 0, 0, 0, pitch, yaw, and roll, and ask the patient if their head feels straight. 85% of patients who are over 2 years of age and have not had their head corrected, the posture corrected, will say that their head feels crooked when you straighten it. They've already has a neural wiring of egocentric localization. It's mal-localized. So some of the recurrent head positioning that occurs after medical, optical, or surgical treatment is actually a persistence of anomalous muscle tone in the neck or egocentric localization, which interestingly can be retrained with some physical and occupational therapy. So how do I treat nystagmus? Well, we treat the visual system, not just the nystagmus, although we'll treat the nystagmus itself. But I think of treating these patients as treating the entire visual system, especially when there's multiple things that are affected, like in patients with albinism, who make up anywhere from 1/3 to 40% of the population of infantile nystagmus patients. And here, I'm not going to read this for you. Here's all of the things that are listed, and I break up the treatment of nystagmus into optical treatment, medical treatment, and surgical treatment. And the non-surgical treatment is optical, medical, and non-traditional treatments such as acupuncture, meditation, especially mindfulness meditation, biofeedback, and educational assistance in their classroom. And the three most important things that I think they need as students, the single most important thing is extra time. It takes patients with nystagmus as long as 5 times to process the same world that it takes you. So if it takes you a second, it takes them 5 seconds. And if you add motion to that, it takes even longer. If you give your patients extra time to read the chart, then you'll see that even their vision will appear to magically get better. And it's just because they're only capturing the world during each beat of nystagmus for a short period of time. In the foveation, it's called the foveation period. And those can be extended or changed with treatment, and also with things like mindfulness meditation. So these are generally the things that I use. Prism therapy, I think, is effective in a couple of situations. Probably the most effective use of prism therapy is for those patients who have good binocular function, even monofixing with some fusional vergence, and have vergence damping. In the office, if you see this and they have binocular function, I'll put them in base out prisms. You can do this in a 4-opter or a trial frame. You have to add a little bit of minus. Don't do this with them cyclopleged to their refractive error, because they get accommodation in induced versions from a CAC ratio. And usually I'll start with anywhere from 8 to 10 and go up to as high as 15 prism diopters, even 18 prism diopters of base out. I've been able to grind it. I was an optician for many years, and I know that the general terminology is, oh, don't put more than 5 in each lens, but I've put 10 in each lens, ground in, base out, in a small eye size, like a 45 or 50 millimeter eye size, and especially if I'm myopic, just decentering the lens in addition to some grinding in prism. And the way that they're put in the modern frames, you won't see a lot of edge thickness, prismatic effect, or jump. So these patients will do well in base out prism. Some of them will do really well if you don't want to do surgery for the vergence damping. So base out prisms is a little bit of over minus. Yoked prisms don't really work well for eccentric null positions, because usually they're 20 degrees or greater, which would be a 45, 50, 60 prism diopters in each eye. You just can't do it. I mean, you can do Fresnels, but then you blur them. And so the blur, the sacrifice you get with blurring the image, doesn't really make up for the retinal image stabilization is really a unique way to improve the vision and visual function, especially patients who are wheelchair bound from serious CNS problems associated with nystagmus. So acquired pendular nystagmus, say with MS, a brainstem tumor, stroke, traumatic brain injury. These patients can benefit from retinal image stabilization using a high plus lens in the frame, in a glasses frame, and then a high minus contact lens. And you can play with this in your office. And you don't have to stabilize the image 100%. It has to be done monocularly. It can't be done binocularly. So for instance, I have a number of patients with severe brainstem disease and acquired pendular nystagmus. Well, I'll give this prescription to, and put a patch on, put the glasses on, and they can sit and eat dinner, converse with their friends and family in their house, or watch television. It's not a commonly used technique, but it does provide some advantage for those rare patients who may not be helped with either medical or surgical therapy for acquired forms of nystagmus. Low vision devices can be extremely helpful. I found that partnering with an expert in low vision, usually an optometrist who spends their life dealing with children or adults with low vision, is very useful in asking them to give them a task-oriented direction. So they need help with near work. They need help with computer distance work. They need help with ambulating around the house, or ambulating up and down stairs or curbs, or ambulating outside. If you direct them and the patient helps direct them, it's much easier. Contact lenses are really an extremely underutilized, especially in the pediatric population, therapy for nystagmus. They provide 4 huge advantages. The first is that the quality of the optics with a contact lens on your eye is much better than glasses, especially in high ametropia. The second is that the contact lenses can move with your eye, so if they still have to use a posture, then they're not getting aberrations from looking away from the optical center. The third is that you can tint the lenses or peripherally paint the lenses, provide treatment for photophobia or light interference, and pain from light are two different things. Patients with albinism and transillumination defects, in addition to getting pain from light, which is photophobia, they also get light interference. And light interference is what happens to you when you go in the movie theater and you try and watch the movie when they turn the lights on. The difference in the quality of the way the projected image looks on the screen when the lights are on and off in the movie theater is light interference. And that can be minimized with a peripherally painted contact lens. And Botox is kind of surgical, non-surgical. Botox for nystagmus is not really a good solution. There is a Goldilocks period where when you give Botox for either acquired nystagmus or even infantile nystagmus, where just the right amount of wearing off, or for lack of a better word, wearing on of the Botox is perfect. So if you could give them that dose in the muscle for whatever it is for that patient all the time, it would be perfect. So say you give 7 units of Botox in 4 muscles, and now it's down to the equivalent of 1.5 units in the medial of the right, 1 medial unit in the medial of the left, a half a unit. It's just worn off perfectly. So there is a Goldilocks zone, which usually lasts over the period of 3 months of maybe a week, where everything's perfect. And then it's either not enough or too much. So until we can find that and deliver and maintain that Goldilocks period, Botox doesn't seem to be very helpful in the long term, although people still use it. The medications that I use, and these are all the listed ones that are used for nystagmus, that I use very frequently, the most common is baclofen. And I know that ophthalmologists, if it doesn't come in a bottle, then they have trouble prescribing it. So maybe we should put the pills in an eyedropper bottle and then take the top off and like squirt it in the mouth. Then ophthalmologists, optometrists, everybody will feel more comfortable. But why not prescribe a systemic medication? Baclofen has such a good safety profile. It's actually pumped into the subcutaneous tissue and bloodstream of children with cerebral palsy. And a significant number of patients with INS will be helped with this, especially the periodic component. The soloist is really well treated in more than half the patients with INS and aperiodicity or periodicity. For acquired nystagmus, Namenda, memantine, 3,4-diaminopyridine, which is Ampyra, can be helpful with acquired downbeat and upbeat nystagmus, anywhere from a third to half the patients. So there's no reason not to, if you don't want to prescribe it yourself, work with a neurologist who's familiar with prescribing it, because using medications, the patients that you can help from this, it's really miraculous. Yes, many patients may not benefit. Many patients don't main benefit. You have to monitor the way that it's dosed and the side effects. And it can take 2 or 3 or 4 or 5 months to find the right group of medications, the right way to help them. But I don't think we should be timid about that. Topical medications for the use of, for the treatment of nystagmus have really grown out of what we understand as a result of the physiology of surgical treatment. And the current hypothesis for the improvement in some of the nystagmus characteristics as a result of surgery are the disruption of an afferent proprioceptive loop, beginning with the proprioceptive nerve fibers in the enthesial portions of the extraocular muscle tendons, where the tendon becomes sclera. And it turns out that these nerve fibers can actually be treated with topical medications. And one of the clinical trials we did was AZOP, which is a carbonic anhydrase inhibitor and seems to affect the sodium-potassium pump channels in the enthesial nerve endings and changes the nystagmus when it's used 3 times a day. And our crossover clinical trial showed this to be effective. And here's just an example of the eye movement recordings on baseline placebo versus a patient on AZOP. There's no treatment that I'm aware of that cures nystagmus. So it gets better, but it doesn't get cured. And I think it's important when we communicate with our families and patients that we maintain that level of discussion, so that the expectation level is not that it's gone, but that it's better. And we've recently discovered through an accident by a patient a topical pesticide. I don't think I can get Ginger's video's not working. This is Ginger, little dog with nystagmus. This is Ginger and her brother Scout. And what we showed in them was that using this topical medication, I'm sorry, these videos don't work, but I can send them out. The video on the left was Ginger with her nystagmus before drops and then after drops by use of a topical pesticide. This article is coming out in the next month. I've waited 11 years to publish this because now it's been patented and we're beginning the human trial of this in the next 6 months to see if this works in humans with nystagmus as well. And this works differently. It has a sodium channel inhibitor rather than a sodium potassium pump inhibitor like the carbonic anhydrase. And so a patient accidentally got this in his eye, and we've studied, and it made his nystagmus better. That's part of this report. And then we did this in some animals that showed it got better too. So it may be that topical therapy is going to work in addition or maybe even instead of surgery. What I see is happening is maybe using these drops during the developmental period of the nystagmus when it's most susceptible to developing the first 3 months of life. So I could imagine a family bringing a child in with the early development of infantile nystagmus in the first couple of months, 3 months of life, and then using a drop to suppress the development until the brain is hardwired enough that it can't develop anymore. And maybe that will be some of our future treatments. So here's the beneficial effects on the visual system patients who've had treatment for nystagmus, including optical, medical, surgical treatments. And you can see all of the things that have gotten better. And these have been all the results of studies that we've done over time in these patients. So that's a quick whirlwind tour of non-surgical treatment of nystagmus. But I think the most important thing to encourage is that, let me get back here so I can stop screen sharing, is to treat your patients. And I still hear now that there's no treatment. That's what I hear. And I see 20 patients a week. Almost all of them, probably 85%, are not from this area. They're from other states around the country, this country and other countries. And the first thing I hear is that they go to see their pediatrician who says, oh, you need to go see an ophthalmologist. And then the next thing, their local ophthalmologist says, oh, there's nothing that can be done. They're never going to drive. I'll see you later. Or come back in a year or 2 years. And unfortunately, that's still the scenario that I hear. And it would be nice to not hear that scenario anymore. But I think it's going to take a few generations. Certainly not going to happen in this generation. I've accepted that. I'm happy to answer any questions.
Thank you very much. It was a very informative presentation, and we've got quite a few questions, if you don't mind. So first of all, about the baclofen, do you start with a smaller dose and then increase it because of the nausea and fatigue and sedation side effects?
I tell the families that they all will experience some sedation and will go away, and I use the recommended doses. So I do 5 in the little kids, 10 in the preteens to teens, and 20 3 times a day in adults. So it's either 5, 10, or 20.
About AZOP, do you still prescribe it even if the patient is going to go for surgery? I mean,
no, the way that I use AZOP is, I use AZOP after surgery, and I don't keep a patient on a medication unless there are clinical and real life benefits. So even though the eye movement recordings may get better, the nystagmus may get better, if a medication doesn't improve how the patient is functioning, then I don't keep them on it. About 50% of the older children who can communicate with me and adults who I've put AZOP on after surgery want to stay on it. They say that it makes a difference and they know if they haven't dosed themselves for a few days. But 50% say it doesn't make a difference.
Okay. Say if you're going to try a new medicine for the treatment of nystagmus, how do you evaluate it? Because visual acuity is not very good to evaluate. So do you have like a specific test that you prefer to? Yeah.
So my patients undergo a very intense, thorough electrophysiological and behavioral vision testing evaluation before as part of my initial and follow-up visit. So they do ERGs, VEPs, OCTs, fundus photos, color testing, contrast, full contrast sensitivity testing, gaze-dependent visual acuity testing, as well as how fast they process vision. So I do all these tests before and after treatment because I believe that acuity testing is the least sensitive test for how nystagmus gets better. So it's really, one of the things I can recommend is that incorporate contrast sensitivity testing, some form of CST, into your practice if you see nystagmus patients, because that's a nice way to document how the visual function has changed. I think it's a better reflector of visual function in nystagmus patients than high spatial frequency vision, Snell and HOTV, whatever.
Okay, if a patient has fusion mount development nystagmus and amblyopia, sometimes they don't tolerate well the patching. So do you have some advice for us?
What children do tolerate patching well? It's
So
the same answer. Same answer. No different.
Right.
Okay. Kyle, do children tolerate patching well in Buffalo? No. Okay. All right. I just maybe send them to Buffalo. That's what I was going to say. So,
You know, the parents don't tolerate it well either.
yeah, that's right. That's right.
So for eye muscle recordings, most of us don't do it, as you know.
Right.
There was, I heard about the spectral domain OCT to be used. Is there a software for it, like the linear cuts?
We did, you know, when I worked with Joel Schumann, who invented OCT, we did some really cool stuff showing how you could use the OCT to look at the nystagmus waveforms with one of my fellows at the time, but that never panned out. And you know what, the market to use the OCT and change the software for nystagmus patients, the bean counter said, no, we're not doing that.
Mm-hmm.
You know, if someone could do that themselves at an institution and say, all right, let's take what Tara did, Tara Cronin, who's on that report, and say maybe make it easy for the Cirrus machine to do that and hand that software out, then you could use it. But it's going to take some programming to be able to do that and make the OCT able to look at the raster and look at the nystagmus waveform.
When do you say this patient needs surgery? When do you recommend surgery?
What's my indication for surgery in nystagmus?
In nystagmus, yes.
Yeah, so I would say that probably 85 to 90% of the patients that I see with infantile nystagmus, I recommend some sort of surgical procedure. The ones that I don't have generally no head position. They don't change with virgins. Their acuities are generally really in the better than 20/40. And I don't feel like I can make any difference in their function. This is with infantile nystagmus syndrome. The acquired nystagmus patients that I operate on, there's some different indications. They may have head postures like chin up or chin down. There are some patients who cannot tolerate the oscillopsia at all, and I do an 8 muscle operation for them. So I have written the indications in some of the literature, but the INS patients, so it's like saying, if I have a patient with a heart arrhythmia that comes in, what's my indication to treat them? Well, they have a heart arrhythmia, I got to treat them. So when I see a patient with an eye arrhythmia, I believe they need some form of treatment. So I think the day of not do we treat, but what do we treat with is we should transition to.
Last question about the gene therapy. Is it out yet?
Yes. Yeah, I think that gene transfer therapy is going to be in our lifetime the most revolutionary thing in medicine, I believe, other than the electronic medical record. For other reasons, is the biggest thing to hit medicine in the 21st century. So we're preparing right now, we're building a gene therapy center here in the Vision Center to utilize all the FDA approved gene transfer therapies that come around. Right now, it's just Luxturna's the RPE65 voridogene that's out, but there's one coming very soon for achromatopsia. I think treating the underlying afferent system deficit during the development or before the development of the oscillation, like we did in the puppies. So these dogs that we treated that were developing the nystagmus with RPE65 deficit, these are different than the dogs we treated for the drop. So the dogs that we treated that were before all the human trials had RPE65 retinal disease and were treated with subretinal injections at the onset, right at weaning of the development of their nystagmus. And when their vision got better, their nystagmus improved. So I think if we could treat the associated visual system deficit, that will treat the nystagmus. As far as treating the nystagmus itself with gene transfer therapy, maybe the FRMD7 in the retina may be helpful or in the brainstem, but we're not sure completely how FRMD7 is causally related to the nystagmus yet either. But gene transfer therapy is going to be part of all of our armamentarium if you decide to continue to practice medicine for the next 10 years. I think we'll all have the opportunity to use that.
Excellent. Thank you so much. Dr.
Sure.
Ahmed, do you have any questions? Dr. Ahmed from the audience, do you have any questions, please? I think Dr. Awadeen is...
I have a question for myself. Okay, again. Okay, one question. What are your tips for objective and subjective diffraction for a child with nystagmus?
Yeah. All right. Well, so I almost always will do retinoscopy. I don't let the machine do it in patients with nystagmus. I'm a little old-fashioned where I feel like my retinoscopy, because I've done millions of them, I think, is better. So objectively, I always correlate what I get subjectively with what I get objectively. So these patients, if they can do subjective refraction, get both. They get an objective refraction with cycloplegic retinoscopy, and then I do binocular refraction. And these patients, a lot of them can do binocular refraction. You'd be surprised how many patients you just have to fog minimally or ask, just use your preferred eye. And then you could do binocular refraction, and they're constantly using their preferred eye during the refraction. If they can't and they switch back and forth, then I'll do the minimal amount of fogging that will change their nystagmus or make them use the non-preferred eye. So I will do a little fogging, but I always do objective refraction to have some baseline. And then what I give them in the glasses, I don't know, that's our experience. That's the art of refraction, right? Which you actually write on the prescription. I can't help with that. We all have our own way of doing that.
Okay. And for how long can you keep a child or a patient on brinzolamide or Azopt?
I don't see any reason. In the adult literature, there's no long-term side effects of it. I haven't seen any in the kids yet or in the adults. I don't have any reason to stop yet, unless someone tells me
permanent treatment.
It causes excessive eating of chocolate ice cream, then I'll have them stop or something. You know? I don't know.
Okay.
Okay.
Thank you, Sir.
Right, sure. Thank you.
Okay, so we're moving to the next talk. So before the talk, we're going to launch a poll. We're going to ask our audience whether to use Botox in their teeth. We have another question. If you're not using a Botox, what is the reason for not using it? Is it because of the cost, because of the unfamiliarity with its use, because you don't think it has a benefit, or because of the need for repeated injections? So Dr. Rosario, most of us feel that we don't know how to use Botox. So you're going to tell us how we are going to make use of it.
Okay, thank you very much. It is a really honor for receiving this invitation of the Egyptian Association of Pediatric Ophthalmology and Strabismus. I would like to thank Dr. Awadeen and Dr. El Basha, and also to Dr. Basak for this very kind invitation. With my talk, I would like to speak a little bit on the treatment of strabismus, and I'm very happy to say that I have a little conflict interest because a lab asked me about how to develop a forceps, and I told them some advice, and finally I saw that they placed my name by the suggestion of Dr. Tuvena. So as strabismologists, we don't have conflict of interest. I'm happy to say that I have one, but I don't win any money about this issue. Strabismus treated with Botox is a very long issue, and I'm only going to tell you a few pearls about the use of Botox. In this paper that we published just recently, you may see all this test a little bit longer, and anyone wishing to know a little bit more of Botox, I suggest to read it. In this talk, I'm going to tell you a few words about and some pearls about the use of Botox, that they are based on very frequent questions that I receive when people come to see treating with Botox. The first question that always appears is, well, which dose do you use? And I say, well, on the world, there are two types of toxin. One is the onabotulinum toxin, which is it is under the name of Botox, of Xeomin, and some others that appear in different countries. And then we have Dysport. A big part of the world use Botox, and the UK is a country that they use a lot of Dysport. Both toxins are very similar. In vitro, the conversion factor between both two is really uncertain. We think it is between 2.5 and 4. But then, in terms of those that we are using on the daily life, they are very similar to the doses that we use. We know that maybe with 2.5, it is enough to cover all the muscle and to have a very marked paralysis, and maybe we should use this Botox, this dose. But we know that sometimes the toxin doesn't reach so well the place, and we use 5 units, and when we want a milder effect, we use 2.5 or 1.25. In cases of fibrosis, we use 10 units. While using this Dysport, that I have very small experience, most of the authors use either 2 or 2.5 units. This toxin is diluted with saline, and we use a volume of 0.1 milliliter, and some others use 0.5 in order to have a smaller volume and to avoid diffusion and to have less complications. We suggest not to open the conjunctiva. Some people try to open to see where they place the toxin, but we know that sometimes only opening a little bit, how much damage we can make on the conjunctiva. And therefore, most of us, when you have some experience, you don't need to open the conjunctiva. There are 2 techniques that can be practiced, either using an EMG recorder, which is very practical if you want to put the toxin very posterior, which is much closer from the nerve, and you're going to have a more severe paralysis. And also that it is important if you want to put a toxin on the inferior oblique in order to differentiate the inferior oblique from the inferior rectus, that they are very close. If the patient, when he looks up and in, increases the sound of the EMG recorder, you are on the inferior oblique, and if it decreases, and even more, it increases looking downward, you are on the inferior rectus. If you don't use an EMG recorder, which for the medial rectus is easy to just to grip the muscle, you can take any forceps, but there are 2 forceps developed, one by Mendoza and another by another lab. That's the one that has presently my name. If you want to inject the inferior oblique, I learned from a Mexican group that they grab on the inferior temporal quadrant until they see the area where the inferior oblique, they take with a forceps this inferior oblique and they inject directly on the inferior oblique. The second question that often we receive is, well, but the toxin, does it last forever? Or how is the evolution after the injection? And many years ago, we developed already how was the curve of the evolution after one inject a Botox. And we see this is the curve that usually has a patient. The curve has a different form depending if you inject one side or both sides. If you inject one side, this curve is a little bit smaller, while if you inject both sides, it would last a little bit longer. And also it depends if you have a marked paralysis from the beginning or just a mild paralysis in which maybe the patient will be straight ahead and immediately the strabismus will reappear. But if you inject properly and the case is adequate, that will be the curve that we have to remind. And at the very end, once the strabismus stabilized, we will have a correction of the deviation that already in the 92, we gave those numbers, and those numbers still the numbers that correct a Botox. Here we have a patient, because we injected on both medial rectus. Here's in the phase of the overcorrection. And in this time, it works because those patients often have spasms and contractures of the medials. The lateral rectus begin to contract. And then also we have binocular and proprioceptive changes that make that at the very end, the strabismus get corrected, but at the long term. It is important that once your patient is aligned, you reevaluate again accommodative factors, because often they are children that they are in a period that they are having infantile esotropia, but also they are becoming to have other associated accommodative factors. And also because sometimes when you have a marked squint, small hyperopias don't correct the squint, and once you block this, deblock this strabismus, these patients may have an accommodative component that can be treated with the glasses. Here we have another case of a small child that received the Botox. Here you see on the overcorrection period with a marked doses that you treat with alternate occlusion in order to avoid amblyopia. And then this child had glasses, and here you see the patient many, many years after, only with one shot of Botox. And here you see the child many, many years with one Botox. So you don't need to repeat every year, like with the wrinkles of the face. The next question that the people ask often is, well, where it works and which are the indications? So on longer series, we publicate the effect of the Botox, and we saw things that now they are very clear. Botox is more efficient in esotropias than in exotropias, but also the subtype of strabismus is important. For instance, an esotropia that has some potential of binocularity has a very high good prognosis to be cured with Botox. The age is also another factor, but it's not that a child of 3 months has a better prognosis than one of 6. The ranges are larger. For instance, a child below age 1 has larger chance than a child of age 3 or 4, and this one more than one of 5 and to 7, and more than one of 15, and so they are not so short the age periods. The third factor is the degree of the deviation. When you have deviations up to 30 diopters, you have a great chance to get them cured with Botox. But if you have a patient of 70, the amount of diopters that they are treated, that can be reduced, is longer. So, I mean, a patient with 30 diopters may be ended ortho, but a patient with 70 diopters may be ended by 25 or 40. So it may be corrected even more, but that's like with surgery. Another factor is technical factors. Of course, if you inject one side, you will have less effect than if you put 2 bimedial injections. If you inject a Botox and don't have quasi-paralysis, you are not going to cure your patient. And then you have other factors. For instance, hyperopia patients are very susceptible to have good results with Botox. Patients with marked fibrosis will have less good results. But of course, as everything with medicine, indications change over the years. And since the 90s to today, 30 years after, many things have changed. So recently appeared a paper in my country of a colleague where she saw what are the indications in her hospital at the moment. And if we see that there are differences, indications, if they are children and adults, children usually are in infantile esotropia or acquired esotropia. Sometimes we use it in intermittent esotropia in order to prolong the period in which we will go for surgery. And she had a big number of nystagmus that in my hands is not so high because I'm not so happy with the results with nystagmus with Botox in children in general. In adults, of course, we have less infantile and acquired strabismus, and the number of oculomotor paralysis is much larger. So if we specify a little bit all those indications, and for sure, and I'm not going to be able to describe them all, I would like just to point some aspects about some paralysis. For instance, in infantile esotropia, we know that with Botox, we may treat children, and it will depend the deviation that you're going to have higher or lower success. So therefore, you may find success that may rate from 59 to the 89. I have two series of different percentage, and recently one of the last one of Campomanes was about 60% of success only with Botox. But why do have a new interest on Botox now again with in the use of Botox in infantile esotropia? It's because if we see the natural evolution of the infantile esotropia over the years, we know that 50% of the patients 10 years after will need a second surgery, and 20 years after, 2/3 of them will need a surgery. So Botox may help to reduce the number of surgeries. We can go earlier on the treatment. We reduce large deviation that will need then less surgery, and we reduce the risk of general anesthesia because we are going to do a very mild anesthesia in a very early period. We don't use, in any case, of infantile esotropia because we see from the very beginning that there are cases that they are much better for surgery. So in general, in our institution, we use Botox in children below age of 12 and sometimes below 24. Even more, if those deviations are not very large. If we see that we don't want to do surgery because they have DVD or inferior oblique overaction that need simultaneous surgery. And it will be what I call an infantile esotropia plus if those infantile esotropias are associated to high aperopia, variable angle, or have a certain delay in their natural evolution. So we will say that this child with infantile esotropia had a very good prognosis with Botox, while in this child, it would be better to go surgery unless you are not going to operate the DVD and you want to do a Botox to reduce the angle, to see what's happening with DVD a little bit later, and to do a surgery for the horizontal of less amount that's which you should need if you will treat this very large deviation. Acquired esotropia, very high success rate because they have a potential of binocularity. And in deviations up to 35 diopters, they are very similar to surgery with lower consecutive esotropia over time. And if you have a consecutive esotropia, you will go on a fresh case without muscle slippage and without scars. But among them, there is a special subgroup that go marvelous. That they are those patients that they compensate late in their age, and then with one Botox, they will have a success rate in our hands in almost all the patients. Psychomotor delayed children is another type of strabismus in which we like to use Botox because we know that they may go IXO over the time. They don't go all very well, but sometimes the rehabilitation is much better when they have smaller squint. And we know that the better prognosis, we have them in those that have less neurological defect and in esotropia versus exotropia. Exotropia is also a type of strabismus that sometimes we use Botox, but much, much less frequent than in esotropia. We use it in infantile esotropia that they are very decompensated in order to delay the age of surgery. But at long term, we know that the percentage of patients that they are going to be cured only with Botox is going to be very small. But we may treat those patients, and they are by average between 9 months and 1 year with eye ortho, and that's allowed them to develop some type of binocularity. Another subgroup that I like the Botox is in some sensory exotropias that sometimes they already have several surgeries and they still have IXO, and the Botox, the repetitive Botox on lateral, you can align them, they are quite comfortable, and the gap between Botox, you augment it over the time. And now with the combination with bupivacaine, sometimes this adding effect has a greater effect and longer lasting effect. Also, I use it in a type of patient that Kyle pointed out because they are very complicated. They are those patients that have consecutive exotropia with diplopia, and you evaluate them with prism, and the diplopia don't disappear, but you use a Botox, and once you put them back in ISO, the diplopia disappear. And sometimes they are a very good period with the Botox, and they are aligned, and they are very happy because they don't see double or they don't have astinopia. And if the squint reappears, if the exotropia reappears, then we will go for surgery because this treatment had a treatment effect, but also a diagnostic effect. And some others use it for the convergence insufficiency exotropia. And then we have many, many other indications, and Botox is a very important tool for special cases. For instance, residual deviations, for instance, a consecutive esotropia after surgery for infantile, for intermittent exotropia, and that doesn't improves over the time, is a very nice treatment with a very high success rate before going to a new surgery. Residual esotropias and small consecutive esotropia. Also, we use it to potentiate the effect of surgery in very, very large deviations, as was pointed by Seyhan Özkan and Dr. Owen and Dr. Khan. We use it very rarely, but also the exception is for some cases of thyroids, for instance, for those who have decompensated strabismus after decompression, orbital decompression surgery. We also use it in Duane syndrome in very small children that they have very marked deviations, and often we think that in those cases they are mixed cases of Duane and partial accommodative esotropia, and also in Aderian syndrome as a traction suture. And then the very big group that if you want to do questions, because it's very difficult to cover it in such a small time, is the oculomotor paralysis, which had 3 principles. To try to recover the recovery period, to treat the contractures that sometimes is the cause of the residual angle and associated to surgery. And to point out this, patient, for instance, with a bilateral cystic palsy, that we received the child because he had a very severe head injury, and 8 months after trauma, he came with such a severe palsy that from a surgical point of view, maybe we'll be treated with transitions, and look at what happened after 4 months after injection of multimedial, how those contractures were really the cause of this paralysis, and how they were treated so well with Botox. So, and that is something that happens very often with bilateral cases, that they have much more contractures when the palsy is the affected eye, and in children that they develop very marked contractures. So in summary, a small group of colleagues all over the world, we have a great experience of the use of Botox in strabismus treatment, and we'll still use it also under certain circumstances that, of course, over the years we have changed them, but we'll still use it a lot. I think that we have to say that both surgery and Botox should be used in the management of our strabismus patients. We use it in some types of strabismus in children, in operated patients, and in complicated cases, and of course, in many oculomotor paralysis. And finally, I leave to Dr. Rogna that she will speak about the bupivacaine that we use it less, but it is also very efficient, isolated or in combination with botulinum toxin. And I would like to thank you very much from Madrid, Spain, from the University Complutense of Madrid, that is a very long-standing university in the country, it's the largest in the country, and from the institution where I work. Thank you very much.
Thank you, Dr. Rosario, for this informative presentation. I have a few questions for you. First of all, why does Botox work better for the medial reactive than the lateral reactive? There is any explanation for this?
Well, I think at the very beginning, we said that the type of fibers were different, and we spoke about the monoinnervate sheet and the multi-innervate sheet, and that was the cause that we always thought. But you know, both muscles are different. But I think that isotropia, we have more spasm than exotropias, and that we have many children in which isotropia has contractures and also has sensorial factors that try to avoid the orthoposition.
And do you add sodium hyaluronate to the Botox to prevent ptosis? Do you add sodium hyaluronate to the Botox?
I don't. I know that there are, I mean, in order to avoid ptosis and diffusion to other muscles, different things have been done. What I try is to put a cotton on it. If I don't want diffusion, I try to place it on the anterior part, but I know I'm going to have less effect. We try to concentrate even more to try to use less volume on the injection, and I try to bring the patient up as soon as possible in order to avoid the diffusion. But I don't use hyaluronate.
Okay. Sometimes when ptosis is prolonged, how would you manage such patients when you have a prolonged ptosis after the Botox injection?
Yes, you know, the ptosis is a aesthetical problem, but you don't have amblyopia because of it. You know, we've used even Botox to try to ptosis on children with congenital cataract, and they put the head up. You know what it causes? Amblyopia, the different paralysis of the different muscles. So if you inject Botox on both medials and you have a great paralysis in this and not so marked in this, he will fix with the eye of the less paralysis. So what we try is, in order not to see the patients so often, and in order that they deal with the ptosis, to close one eye when they go to the street. So they go when they go to the street, they patch the eye with greater ptosis, so no one watches them. And at home they try to go with the eye with less ptosis. And we try to do alternate patching for the smaller ones for the first month, and then we do only a couple of hours of patching. Ptosis in elderly people sometimes lasts longer. I think the elderly people recover late after surgery, the paralysis recovers later itself, and the ptosis also recovers later.
Okay. Recently, there have been new drugs such as immunotoxin and such as insulin-like growth factor. The immunotoxin is alternative to Botox, and the insulin-like growth factor instead of the bupivacaine. So are they clinically beneficial or up till now just experimental work?
Well, studies are very beneficial, but the legal aspects are very complicated. We have to say that we used Botox in the 80s, and still the use of Botox in children off-label. So it is a very difficult issue, and the day that we can obtain exactly the palsy that we wishes, and to try that it comes on and off whenever we wish, that will be the day. I mean, as said Dr. Hertel before, I mean, Botox for nystagmus, if we could say, well, we want to stop that much, so much time, that will be the day that, I mean, that will be the good toxin that will help us to treat.
Thank you, Dr. Mario. Maha, do you have any questions?
Yes, we have a couple of questions here. When you're giving general anesthesia and with Botox, some of the anesthetics are muscle relaxants. So do you prefer a particular type of anesthesia?
Well, that comes from the very beginning. At the very beginning, because we wanted always to use ketamine, because we wanted to hear very good the electromyograph. And then we switched to others methods, even fluotan. So, and even you can record a little bit the muscle using those relaxant products. The only thing is to try to be prepared to go very quick on it. But of course, in children, often many people don't use EMG recorder for the medial rectus. So for many, it's not necessary to use a special product for Botox. Maybe for the inferior oblique, but then you are not going to ask a sleeping guy to look up or down. So I think today we don't use ketamine anymore because it was complicated, and we use protoxide nitrogen, even with serofluorine, but we go very quick if you want to use an EMG recorder.
And to vary the amount of surgery, do you vary the position in the muscle anteriorly or posteriorly? Because posteriorly is more effective. So
it depends.
Do that.
Yes, it depends very much on what you want to obtain. For instance, if you are dealing on an oculomotor palsy, a 6-nerve palsy, and you want just to recover the patient earlier, because he has to be very active, I will use a very small dose and very anterior. Because if I have a diffusion to another muscle or a very marked paralysis at the very end, the duration of the recovery of the Botox is longer than the palsy itself. But if you have a very severe angle that you want to treat, it's better to go behind, because you are going to have a ptosis. The patient knows that it's going to last 1 month, but you will have a larger effect.
And the last question from the audience. What to tell the parents, when is the maximum effect of the Botox?
I mean, when it's stable, you understand?
Pardon me?
When
yes, exactly.
Stable. It depends very much on what happens the follow-up before. You saw the curve, and I say that if you use Botox bilaterally, to say that your patient is cured 6 months after, that is not fair. You have to wait 1 month. But what it is important is, if one patient didn't have a very marked paralysis, and you have 3 months after the patient ortho, well, you think that maybe he will come back. But sometimes they have good vision and they stay forever like that. And you see 3 months after, 6 months after the injections, that he is ortho. You think that is going to be something that maybe is stable. If you see him 3 months after ortho, you know it's stable. But see case B, a patient that has an exotropia after the injection. The patient, you see it at month 6, and he's still exophoric. Well, see him 3 months after, and he's ortho. I wouldn't say is stable. I will look 3 months after. So 6 months of stability, you ask for saying I will count as a success.
Okay, thank you very much. Thank you very much. So our next speaker is Dr. Lubna Hasbak with her presentation about the use of bupivacaine in strabismus. Can you please share your screen?
Hello, everybody. I have no financial disclosure about the products in this presentation. Bupivacaine was first discovered in 1957. It's a local anesthetic of the amide group. Of course, it is used for ocular, periocular, and retrobulbar anesthesia in doses of 0.25 and 0.5%. Its action begins within 15 minutes and lasts up to 8 hours. Sometimes it is available mixed with epinephrine to make it last longer. It is known to cause considerable myotoxicity and neurotoxicity. Its injection into the muscle tissue first leads to dramatic degeneration of the muscle fibers, accompanied with moderate inflammatory response, and subsequently it leads to activation of what we call satellite cells to proliferate over 10 to 20 days with thickening and strengthening of the muscle. This has been proved by magnetic resonance imaging and ultrasonography after injecting the muscle with bupivacaine, as Scott reported that it increases 6% of its normal size after the injection. The attention of bupivacaine is increased after reporting strabismus following peribulbar anesthesia, and as we have cases referred by anterior segment surgeons who did cataract surgery with periocular injection, and the patient developed diplopia after the injection with inferior rectus strengthening and tightness. Scott and colleagues in 2007 and 2009, they proposed the use of bupivacaine, whether alone or in combination with Botox, for correction of strabismus cases. What is the theory and how does it work? When we inject the muscle with bupivacaine, there is induced hypertrophy of the muscle, of the agonist muscle, which rotates the eye in its direction and traversing a shorter path, while its antagonist traverses a longer path, and the eye, this results in adaptive length changes. However, following this transient increase in muscle size, the condition becomes stable and the muscle becomes stronger with lessening the deviation. The side effects of injecting bupivacaine is sleepiness, muscle twitches, ringing in the ears, diplopia sometimes, low blood pressure, irregular heart rate, and sometimes some reported orbital inflammation. The available vials of bupivacaine, 0.25% and 0.5% and 0.75%. 0.75%, it is not available in Egypt, but we bought it, especially we get it from Germany for the sake of using it in strabismus treatment. However, it can be prepared up to 3% in the lab. This study was performed in Cairo University Pediatric and Adult Hospital. We included 76 cases of concomitant horizontal strabismus, patients with post-operative residual or consecutive deviations, and patients with residual strabismus after correction by the glasses. And we excluded patients with concomitant strabismus, children below 2 years, and cases with paresis, mechanical restriction, or any systemic disease that may affect the muscle, and any significant A or V pattern. We included patients aged from 2 years up to 22 years, males and females in that distribution, and we divided them into 3 groups. Groups with angle less than 16 prism diopter injected with bupivacaine 0.75% into one each eye. Group B, larger angles, 16 to 30 prism diopters, were received the Botox injection, 5 units in each muscle, whether both lateral recti in XD or both medial recti in esotropia. And group C, angles larger than 30 prism diopter, where we combined Botox injection and the technique of injection after topical anesthesia in adults or general anesthesia in children, the drug, whether Botox or bupivacaine, is directly injected into the muscle using this specially designed needle electrode connected to electromyography apparatus and the syringe containing the drug. In children and uncooperative patients, of course, the procedure is done under general anesthesia, light anesthesia, and very early. It takes minutes. In this study, we expose the muscle by very small conjunctival incision below its lower edge, and we inject directly into the muscle. This is for the sake of the study to see is the bupivacaine percolates outside the muscle or stays in the muscle, as it is known that bupivacaine does not spread along the muscle, but as we use lower concentration, 0.75% only, not 3%, so we have to use 3 milliliters of the drug. So we want to know how much the muscle, according to its size, takes the whole amount, the 3 cc, or some of it percolates out of the muscle. In adults, there was no problem using topical anesthesia with EMG guidance. We put the needle of the EMG into the muscle and ask the patient to move his eye, and we record the maximum signals, and we inject at the site of the maximum signal recorded by the EMG device. This is the portable EMG we used during this study. We standardized the amounts we use and the concentration. We use 5 units of Botox and 3 cc of 0.7% bupivacaine. In the bupivacaine injection, we inject into the posterior part of the muscle. And then we go to the middle part of the muscle, and while withdrawing the needle, we continue injection for the sake that the drug will go to the anterior part of the muscle. As if we cover the whole muscle, the effect is much better than if we put it in a certain place, whether posterior part, which is better, and not the whole muscle. These are the drugs we used: the botulinum toxin and the bupivacaine, which we brought it specially from Germany. The post-operative care, we give antibiotic, corticosteroid drops, and ointment for 2 weeks. But after bupivacaine, we give intramuscular corticosteroids in children and oral corticosteroids for 5 days in adults to prevent orbital inflammation. And this is recommended by the pediatricians and pediatric anesthesiologists to avoid orbital inflammation, which has been reported in other studies. This is the percentage of angle improvement. Group A with the bupivacaine group, as you see in the esotropia, where we inject the lateral rectus, 75% are have improvement in their results, while in exotropia cases, 100% improve as we inject, in this case, the medial rectus muscle. So injection of the medial rectus muscle gives better results than the lateral rectus muscle. In the Botox group, which is group B, in the esotropia, as we inject the medial rectus muscle, improvement occurs in 100% of the cases, and the effect is less when we inject the lateral rectus muscle. If we combine the Botox with bupivacaine, esotropia cases show much improvement than the exotropia cases. As we see here in this table, there is significant improvement in the angle post-operatively after 6 months of injection in all cases and in all groups. the average amount of correction after 6 months. In group A, the average correction in esotropia and exotropia is almost 5 prism diopters. The Scott reported 8 prism diopters, which is higher than our results because he used up to 3% of Botox and up to 5 milliliters of, of bupivacaine and up to 5 milliliters, and we used 0.75% only and 3 cc of the drug. In group B, the improvement in esotropia, the average is 20 prism diopters and in exo 10, and in group C, the combination of Botox and bupivacaine, esotropia also, there is much more improvement in the angle than in the exotropia. What's about the stability? Here, these after 3 months and 6 months, as we see in bupivacaine group, the esotropia cases are much more stable than the exotropia. In Botox cases, it is almost equal after 6 months, and in group C, with the combination of both drugs, here also the esotropia cases are much stable than the esotropia cases. Miller et al. In 2013, I think, studied the stability and reported the condition, the cases of bupivacaine injected cases to be stable up to 3 years, which is a very long stability. Here are some examples of the children. Here, the group A, where the bupivacaine was injected in the agonist muscle. Here, the esotropia, we inject both lateral recti. And there is a little bit some consecutive exotropia after 3 months and after 1 month, and then after 3 and 6 months, the eyes were aligned, perfectly aligned. However, in exotropia, we inject here the medial recti with bupivacaine, and also there is improvement in the angle and stability up to 6 months. Here is the group of injection with the Botox. Esotropia, we inject the medial recti. Ptosis occurs and consecutive exotropia after 1 month, and then after 3 and 6 months, the eye were aligned. In exotropia, after injection, there is some consecutive ESO. After injecting the Botox in both lateral recti, some consecutive ESO, some ptosis which improve. Usually the ptosis improved after 1 month, and the consecutive deviation also improves after 3 to 6 months. Group C, where we combined with a large angle, more than 30 prism diopter, we combined the Botox and bupivacaine. Here is the esotropia group. Due to the injection of Botox, there is consecutive exotropia, some ptosis, but the condition improved also after 1 month. And in the here in the exotropia, we inject the bupivacaine into the medial recti and Botox into the lateral recti. As you see, always the or mostly the bupivacaine injection comes with some subconjunctival hemorrhage, and the exotropia and the Botox with ptosis, which improved, as we said before. The complications which might occur in the bupivacaine, almost 50% of the cases developed subconjunctival hemorrhage, while in the Botox group there is consecutive deviation which improves, and ptosis which improves after 1 month. What we noticed that the incidence of ptosis was found to be inversely proportional to the body mass index. Whenever there is a low body mass index, there is a higher incidence of ptosis in such cases. The use of higher concentration, 3% of bupivacaine and larger volume up to 4.5 milliliter, of course, is going to improve the results. And also maybe adding epinephrine due to its vasoconstricting action may increase the bupivacaine effectiveness along the muscle tissue. In conclusion, the use of Botox and bupivacaine are good alternative to surgery in certain situations. It's a low-cost procedure than the surgery. In adults and cooperative patients, it does not require general anesthesia, and children, it requires light anesthesia, and it's a very short procedure. The Botox is effective in cases of esotropia than exotropia. Bupivacaine is more effective in small angle exotropia compared to esotropia, and this may be due to the injection into the medial rectus, whether by bupivacaine or Botox gives much more and better results. Maybe due to the size of the muscle, and bupivacaine injection depends on the size of the muscle and the amount of muscle fibers. I think Scott injected the bupivacaine in cases of sixth cranial nerve palsy, and he found that if the lateral rectus is atrophic, the bupivacaine is not effective if injected to treat the esotropia, but if the lateral rectus is not atrophic, the results are better. So the muscle tissue, the presence of good muscle tissue means better success if we inject bupivacaine in. Amblyopia patients, of course, show poorer and unstable results, so the potential for binocularity and the presence of binocular vision improves the situation, and also improves the stability of the results of the injection, whether in cases of Botox or bupivacaine. Injection shows no scarring, so if you have the chance that if you have an unsatisfactory result, you can re-inject the cases, whether with Botox or bupivacaine. In our study, we don't re-inject cases up till now. However, Scott re-injected his patients with bupivacaine after 2.5 months of the first injection, and he in 2 cases, and he got good results in one case and overcorrection in another case, and this needs to be more studied when to do re-injection of bupivacaine and how much to inject. And if you have also unsatisfactory results after additional injections, you can do surgery, and the area of the surgery has no scars and no obstacle to do successful surgery. Thank you very much for your attention.
Thank you very much. Yeah, your presentation was fantastic, and you basically answered all the questions that we had for you. So I think I just want to ask you about when you operate on the muscle, would it be really bulky and bleeding and something like that, or just
after the bupivacaine injection?
Yes, exactly.
Yes, it's much more bulky, but it is recorded by the MRI that it increases in size up to 6% of its original size. So it is much more bulky. Bleeding occurs during injection, actually. Yani incidence of bleeding occurs during injection of bupivacaine, but we don't add epinephrine to it. But during surgery, I didn't notice any difference.
Do you vary your surgical numbers?
Because it spares the vessels. It doesn't affect the vessels.
Mm-hmm. Do you vary your surgical numbers when you're doing surgery on a muscle that has been injected before with bupivacaine?
Yes, but still there is no actual nomogram. So, and there is no big numbers of doing surgery on a bupivacaine injected muscle to say how to modulate your results.
Okay, and in literature, it has been reported that the use of bupivacaine with a recession of the antagonist. So would you recommend this, or what is your
I think if you want to do injection, it's better to do bupivacaine with Botox and to avoid surgery. It is not meaningful to do surgery with injection if you have another alternative to surgery, which is the Botox. I think this is better.
So thank you very much. Dr. Ahmed, if you have any questions for Dr. Lubna.
No, actually, you answered all questions.
Excellent.
I'm very happy. I proposed the idea of non-surgical treatment of strabismus to be a webinar because the surgery has been a lot discussed in many webinars. So this area is not tackled too much, and I'm very pleased to have our eminent speakers, Kyle, Hertel, and Rosario, with great experience, and we hope to see you again, whether on webinars or in actual conferences, especially in Cairo. Inshallah.
Thank you, Dr. Lubna. Unfortunately, Dr. Rich Hertel had to leave the meeting. So in conclusion, on behalf of the EPOS team, really, we'd like to thank you all. And of course, the guest speakers for coming, and hopefully we will see you again, but next time in Egypt. So really, it was amazing and very informative. And also, our dear audience, we're very sorry if we couldn't answer all your questions, but we promise you that we'll collect them all and send them to the speakers, and hopefully they will be posted on the page. And thank you really very much. And Dr. Ahmed Awadin, it was a pleasure working with you, and thank you. So have a
Thank you all. Bye. Have a great great evening. Okay. Bye.
Stay safe.
Stay safe. Yeah.